Great, thank you, and welcome everybody to our webinar this afternoon. I appreciate everybody joining in and learning about the system that the SRTR is working towards for public reporting of transplant program evaluations. We've recently changed the way that we display these information on our website, and the goal of today's webinar is to talk through sort of the history of that change, or what that change means, some of the feedback that we've received, and where are we headed from here. So again, thank you for joining us. We hope this is the first of many educational webinars the SRTR can bring to the community. Here's an outline of what I will cover today. I'll start by just reviewing the SRTR's role and responsibility to report transplant program performance metrics publicly. I will review the previous three-tier system that's existed on the SRTR website for a number of years, so you're familiar with that. And that motivates why we were looking to change it to try to improve the communication of those concepts to the public. And that leads us into understanding the five-tier system that the SRTR has put forward. We will review the feedback that we have received to date and some of the controversies surrounding the change. And then we will conclude with a question and answer period. Again, you can submit questions at any time during the webinar. We will address them at the end of the webinar as time allows. So here I've arrived at our first polling question. What we really want to understand is the types of folks that we have tuning in with us today. And so the first poll is up on your screen. You should see it to the right. And we're just interested in whether you are a transplant professional, a transplant patient, a family member of a transplant patient, if you yourself are a living donor. We're only allowing you to check one here, so please pick the one that best describes you. I recognize that there may be more than one person in your room listening with you, so just select the choice that best represents who you are. And I think the poll is open. We'll allow a bit of time for this to complete. Great, the poll has now closed. Thank you for responding, and in just a moment we should be able to see the types of attendees that we have joining us today. It takes a few seconds for the polling questions to compile, so thank you for your patience as we await the results. So here we see the results. It looks like we have the biggest representation is the transplant administrators, other transplant professionals, some of the other transplant researchers, a few patients, physician, surgeon. So great. We were hoping to attract a mix of individuals for this webinar. So this is fantastic. It was helpful for us to see the types of folks that are joining in. I have one other polling question for us, which you'll see on the next slide. And we're just trying to get a sense. We know that lots of folks register for a group of people. So wondering if it's just you listening in, or are you with a team? If it's you plus one, you plus two. We'll open this poll up and just give us a sense of the total attendee list. Just helps us for future planning of webinars, hoping to reach as many folks as possible. So we'll leave this open for a second while we get a sense of the numbers of people that are online. All right, the poll is now closed, and we should see the results here in just a moment. Again, we're hoping that we can bring more of these types of educational webinars to the community, and so this just gives us a sense of planning and the types of folks that are tuning in and interested in learning about these types of issues. So I think most people are alone. Some have others in the room with them as well. So this, again, gives us a good sense of total attendance, which is very helpful to us. So thank you for participating in those polls. Let's jump right in. Let's first talk about the SRTR's role and why SRTR evaluates transplant program performance at all. This slide here illustrates the oversight system of the SRTR. SRTR is a federal contract. If you read this slide from the right to the left, I'll start sort of over at the right where the SRTR and OPTN are. Those are both federal contracts with the Division of Transplantation, which exists within the Healthcare Systems Bureau of the Health Resources and Services Administration of the U.S. Department of Health and Human Services. So the OPTN, which is the Organ Procurement and Transplantation Network, they run the transplant system for the country. Their contractor is currently United Network for Organ Sharing in Richmond, Virginia. The SRTR is the Scientific Registry of Transplant Recipients. We are located in Minneapolis at the Minneapolis Medical Research Foundation. And in partnership with the OPTN, our role is shown here on this slide. Our mission is to provide advanced statistical and epidemiological analyses related to solid organ allocation and transplantation in support of the Department of Health and Human Services and its agents in their oversight of the National Organ Transplantation System. Lots of words there, but essentially the SRTR exists to provide advanced analytics, the system in the United States. Some of the major deliverables that we provide, we support the OPTN committees, the policy-making bodies, with advanced statistical analyses. We also are charged with evaluating the performance of solid organ transplant programs as well as the organ procurement organizations. Lots of words on this slide. I've bolded and highlighted a few just to draw attention. I wanted to bring up the specific contract language with HRSA for the SRTR, and SRTR's task 3.9.1 is that we are to develop PSRs, that stands for Program-Specific Reports, on the performance of transplant programs and organ procurement organizations, or OPOs. The emphasis that I've added on this slide is my own, just to draw your eye to a couple key phrases. In this first bullet, we are to disseminate for free over the internet timely and accurate program-specific information on the performance of transplant programs according to the final rule, which I've excerpted below. In that second bullet, the transplant program information shall include a number of things, but most importantly for our discussion today, the post-transplant outcomes. And third bullet here, transplant programs and OPOs with better or worse outcomes shall be identified. The language in the final rule that was referenced in the first bullet is below, and this is the governing rule, the federal rule that governs the operation of both the OPTN and the SRTR, that we are to make available to the public timely and accurate program-specific information on the performance of transplant programs. This shall include free dissemination over the internet and shall be presented, explained, and organized as necessary to understand, interpret, and use the information accurately and efficiently. And some of those last concepts, organized as necessary to understand, interpret, use information accurately and efficiently, I would say this is what's really driving us to try to improve the way that these information are provided publicly. So how are we doing this? I put this slide up as an illustration of the challenge that we have in front of us. What you see here is lots of green dots on a plot, and I'm going to take a minute to just explain what you're looking at so that as we see more of these types of figures, you'll have a reference for what we're talking about. Each one of these green dots represents an adult kidney transplant program in the United States, of which there are about 250. So there are about 250 green dots on this plot. They are organized from left to right by the size of the transplant program. And by size, I mean how many transplants did they perform in that evaluation cycle. So if you see a number of about 100, that means they did 100 adult kidney transplants in that evaluation cycle. Bigger programs are to the right, smaller programs go down to the left of this plot. On the vertical axis from bottom to top, this is labeled the hazard ratio. It's a fancy statistical term, but essentially what we're talking about is a comparison of that transplant program's outcomes to what would happen if they were performing consistent with the national performance of other transplant programs with similar candidates and similar donors. If a program, you'll notice there's a horizontal line at about 1. A dashed line is not about 1, right at 1. If a dot is right on that 1.0 line, that would suggest that they aren't any higher or any lower than national expectation. They're performing exactly at what we would expect for the types of transplants they're performing, the types of donor organs they're using. If they are higher than 1, let's just take, for example, if they were all the way up near 2, that means their failure rates for those transplants are double what we would expect, so it's a factor of 2 higher than we would expect based on the types of donors they're using and the types of transplants they're performing. Conversely, if they're at the bottom of this plot, about 0.5, that would say that their failure rates are about half what we would expect. In other words, they're having lower failure rates, higher success rates as you go to the bottom of this plot. And so this, when you look at all of the programs together, we have this jumble of green dots. And what we're trying to be able to do is convey simply to the public, where do programs stand in relation to their peers on this plot? Are they at the high end? Are they at the low end? Are they in the middle? That is the challenge before us. That's what we're trying to do, to convey a simple metric to the public that describes this plot without having to understand all of the information that I just shared with you about how this plot is constructed. Now, how have we done this before? I'm going to step back and I'll show you some images from our previous website before we launched the updated site. We called this system a 3-tier system. In other words, we tried to divide up those points into 3 buckets of program performance. And I'll show you what that looks like, and then we'll talk about why did we think we needed to move on from this system. This is an example of the table that used to exist on our website, and I've just excerpted a couple programs here as examples. What you see in those columns with the orange and teal and red boxes, they say as expected, higher than expected, or lower than expected. These were our 3-tier designator of where that program's performance was relative to their peers. And we reported this separately for those recipients who received a living donor organ on the left, as well as those recipients that received a deceased donor organ on the right. There are a lot of other numbers on this plot, and I've cut off the header. I'll show you another example in a moment that has the header, but some of those other numbers are the numbers of transplants they performed, how many people are on their waiting list, etc. The columns with the NAs to the right are for pediatric outcomes. So if these programs didn't have a pediatric evaluation during that period, they all show NA, which is indeed the case in these examples. So how did we arrive at these as expected, higher than expected, lower than expected? Let's talk about that. Before I get there, I'm going to mention this one a few times. Our colleague here at the SRTR, Dr. Israni, has an AHRQ-funded R01 project, which is a federally sponsored study to create patient-centered report cards. They are partnering closely with us, he and his postdoc, Corey Schaffhausen, to study and elucidate for us, help us find ways to present this information more clearly to the public. And so I'm going to show you a couple places in this presentation, some results that they're finding. And this is one good spot to show some early work. They had conducted a survey of the general public looking at that chart that I showed you about the old website, just with a blinded hospital example here. There was actually a number of hospitals shown, but I've cut them off so we're seeing just hospital A. And they were seeking feedback. Is this chart helpful? What do you not understand here? And you'll see some of the feedback that we've compiled here. This chart is not user-friendly. As near as I can make out through the haze of unexplained acronyms and statistics, patient survival saying as expected was important to me, although almost all of them say that, and the numbers seem to vary a lot. And then somebody said, I don't really understand any of this chart. So this was a sampling of feedback. We got their survey results showed a lot of comments like this. We're trying to improve the way we show this information to the public. So it's sort of a motivation for us to move on and try to improve this. Let's talk about how those 3 tiers were calculated. They were based on a statistical test, and that test was trying to answer this question. is there strong evidence to suggest that the program's outcomes are not consistent with national expectation? And what do we mean by national expectation? We mean that the outcomes of that other programs achieve with similar transplant patients and similar donor organs. And again, this is a question, I think a couple key things to think about in that statement at the top there. Is there strong evidence to suggest that the program's outcomes are not consistent with national expectation? It's a valid question to ask, and what happens when we ask that question? This is the tiering system for those same green dots I showed you before. Again, these are the kidney transplant programs for adult components of transplant hospitals. When we do this stratification into those three tiers, you can see the blue dots at the bottom would be the programs that fall into the better than expected, and the pink dots at the top of this plot are those that fall into the worse than expected tier. So those pink dots at the top have event rates that are about double, 1.5 to 2 times higher than national expectation, and conversely at the bottom, they're better than national expectation. One thing that's evident here, and I'll show more data on the next slide for other types of transplants, is if you look at the green cloud that still exists in the middle, there's quite a range of performance evaluations across those green dots. Indeed, there's some up around 2.0 that are still within the green area, and some down toward the bottom at 0.5 and below, still again within the green area. And so we have this large variation within that middle tier. Indeed, for the kidney programs, about 94% of them are within the green dots. And so very few are ending up in the pink and the blue because of that requirement that this test is requiring strong evidence that they aren't at 1.0. So they have to be far away, they have to be fairly large for us to have good data to make that type of conclusion for that type of test. This table presents how many programs fall within the worse than expected or better than expected tier under the three-tier system that existed previously. And you can see the kidney row here, these are those kidney programs, how many were in the worse than expected and better than expected. Those were the pink or blue dots on the prior slide. And you can see even for if you look at the heart row, which is the top row, we had one program that fell into worse than expected and one program in better than expected, and 121 programs in the as expected grouping. A very similar stratification down for liver programs. We had 0 in the worse than expected, 3 in the better than expected, and 121 in the middle grouping. Likewise for lung, 1 program in the top, 1 program in the bottom, the rest in the middle. And so one of our concerns is this helpful for patients when they're looking at outcomes at transplant programs, when very few programs make it out into that strong evidence realm, such that they can be put out in this worse than expected, better than expected tiering. Just to maybe visualize this one other way, this plot shows 5 sample programs. These are actual real evaluations for 5 programs, kidney transplant programs in this case. The top row is one program whose evaluation was at 0.42. Now that would say that, remember, a 1.0 here would be right at national expectation. Lower than that is better. So 0.42 means that their death rates were about 60% better than what was expected. And that program reached that level of significance such that it didn't, the horizontal bar through the 0.42 line represents our confidence interval, credible interval for where that evaluation really exists, because there's some uncertainty anytime we measure these outcomes. Because that doesn't include 1 in that bar, we would classify that into the better than expected. At the bottom of the slide, you see 1 program here, an example in the worse than expected, with a hazard ratio 1.5. That says that their event rate was 50% higher than what we would expect. Those are fine. In the middle, we have programs B, C, and D, which are those 3 middle programs. All of these show in the as expected tier in the 3-tier system. Although the program B, their actual observed event rate was about half what we'd expect. The program in the middle, their observed event rate was right about 1, right? So this program actually is performing at what we would expect, even with some variation around that estimate. And then program D at 1.9 is to the right of that line at almost double the event rate, even though all three of those would show as expected survival on the three-tier system, even though their outcomes varied quite a bit across those three programs. Finally, one thing to look at on this slide is that there's this program D with the 1.9. Their actual observed failure rate is higher than the program below it with a 1.51, even though that program below it, because it was larger, we had more certainty about that estimate, shows as worse than expected, and the program above it, program D, would show as expected, even though their failure rate is higher. So it's sort of an unanticipated or not ideal scenario. Can we do a better job here of stratifying these programs out into more distinct levels of performance with the goal of being able to compare relative performance across these programs? This plot is just meant to describe the variation within each of the three tiers from that three-tier system. And what you're seeing here is at the worse than expected at the left, better than expected at the right, and as expected right in the middle. What these box plots are showing you, we call these box plots, they're just showing you for programs rated in that rating in the three-tier system, what is the actual variation in their outcomes? And so you can see if you look at the worse than expected, that box plot is telling us that most programs have event rates that are about between 1.5 and 2, because that's where most of that box is laying there on that vertical axis. And on the right, conversely, the better than expected, they're all down below 0.5 approximately. But in the as expected group, we have this wide variation in program performance as observed. In fact, there's a fourfold difference in program event rates within the as expected tier. And so one of our goals was try to come up with a system that better differentiates the observed performance in these programs within that as expected tier. Can we better stratify out programs there to bring better information to the public? That was one of our goals. So in summary, the limitations as we saw that with the three-tier system is the three-tier system was never designed to summarize provider performance relative to other providers. Remember, it was designed to answer the question, do we have strong evidence to suggest that their event rate is not in accordance with national sort of average event rates? So it wasn't designed to do a relative performance review of different program outcomes. It's based on a statistical test that often lacks sufficient information to draw strong conclusions in all but the largest programs. And so most of the programs that were ending up in the worse than expected or better than expected buckets were the larger programs, and there wasn't much differentiation for the smaller transplant programs. And again, the vast majority of programs were in the as expected tier, while graft failure rates varied fourfold within that as expected tier. So one of our goals is to find a system that better differentiates performance particularly within that middle tier. So how did we end up with the new 5-tier system? I'll start with, going back in time a bit here. In 2012, the SRTR and the OPTN jointly hosted a consensus conference on program surveillance and quality metrics. And we published in the American Journal of Transplantation the full report from that meeting. So if you're interested in seeing all of the recommendations, you can find that report on our website under the public publications area of the SRTR.org website. But I pulled out sort of a key recommendation related to this rating system from that conference. And that recommendation was in blue here, that program-specific reporting would benefit from tailoring and education targeted at stakeholders and end users, particularly patients. There was a strong sentiment at the meeting that we need to make these reports more digestible to patients. Some sub-bullets that came along with that recommendation: we need to improve the understandability of public data reporting. We need different analyses and different presentations of the outcomes for different stakeholders, be it transplant programs, be it patients, be it donors, et cetera. And again, I just split these recommendations into 2 slides. So the recommendation in the blue box is still the same, but a different sub-bullets here. One of the recommendations from the conference was this notion of these tiers. The actual example put forward at the conference was to use an analogy to storm warnings. that we have some programs that we might want to say, hey, there's an actual storm warning here, avoid this program. Then there's a storm watch, there's a clear day kind of analogy. So really getting at this idea of, can we stratify programs out into these types of tiers that really give more information. There was a sentiment in the next bullet down, what do patients want from these data? Do they understand what they are already seeing? Could it be presented in a more understandable fashion? And interestingly, this concept came up to that we should set thresholds that foster reaching the top as opposed to just avoiding the bottom. The idea behind that comment was that the current system, where we've got very few programs landing in the worse than expected, the sentiment was that programs were trying their best to avoid ending up in that bottom worse than expected bucket. But there wasn't this incentive for programs across the range to get better all across the board. And so this was an idea that could we set different thresholds such that it would foster this idea that just because you're not in the bottom bucket might not mean that you can't improve and reach the top. So what did we do following that meeting? We went on to start to study this. Immediately following that consensus conference in 2012, we began discussions with our advisory committee. And we call our advisory committee the SRTR Visiting Committee, or SVC for short. That is a team of transplant professionals that guide us and give their advice on what we should be pursuing, what we should be doing to support our contract. So we started discussions with them actually the 1 month following the consensus conference, really diving into this issue. How can we change the 3-tier system and the website to better represent these outcomes? In 2013, we continued to develop this methodology. We presented to the Alliance's Transplant Center Task Force some early concepts. We presented the OPTN Patient Affairs and the MPSC Committee. In 2014, we presented early concepts to the Transplant Administrators and the Transplant Coordinators Committee through the OPTN. And we had a good presentation with HRSA senior leadership on the topic in 2014. Following into 2015, we finalized the methodology with our visiting committee, and we initiated at that point the new website build that would display these new data. In 2016, then, we presented to the OPTN's COIN program leadership, and the COIN leadership actually used the tiers to look at some of the hospitals to identify best practices for their COIN project. We presented to the Transplant Quality Institute and presented to the Advisory Committee on Organ Transplantation, which is a Health and Human Services committee that advises the Secretary on issues pertinent to transplant. And then finally, at the end of 2016, we launched the new site. One of the things we consulted quite a bit, and this document is available through the AHRQ website. AHRQ is the Agency for Healthcare Reporting and Quality. They published a best practices guideline in public reporting in June of 2010. This document was read by our visiting committee, read by the staff here at the SRTR, and we really used this as a guide as we developed some of these ideas. The citation is there on the slide if you would like to look up that report. I pulled 6 key recommendations from that report that we use to guide us in our efforts. The report said we should attempt to make it easy for consumers to understand and use the comparative information. We should try to reduce the cognitive burden. I like that term. Sort of reduce the level of thinking that has to go on by summarizing, interpreting, highlighting meaning, and narrowing options. We should rank order by performance as opposed to alphabetical ordering. The previous website did just simply list programs in alphabetical order. The new website does follow this recommendation to sort the programs by the outcome rating. We should use symbols instead of numbers. In other words, don't use numeric indicators for the metrics. Come up with some kind of symbol that better conveys the idea. Excuse me. So we should provide an overall summary measure, and we should include fewer reporting categories. They give the example of, go 5 categories rather than 9 or 10 or more reporting categories. So the 5-tier system is what was settled on. This new website launched in December 20th of 2016. It's just a little snapshot of the top of the page here. We put a find and compare transplant programs link right at the top that exists on every page on the site, so you can quickly navigate to search for programs. And I'm not going to go into the detailed methodology of how the 5 tiers are calculated, but the website does have a detailed document describing how this happens. Essentially, what this plot is showing is we have this probability distribution, which is this blue bell-shaped curve, that summarizes our best guess of where this program's performance rating is, and we convert that bell-shaped curve into one of the 5 tiers. Again, there's a document on the SRTR website for those interested listeners that want to see more detail about how this happens. But this is what the new search results look like. Polled just 3 centers in the Chicago area within Illinois. And you'll see here, again, rank ordered by the outcome assessment, the 5 tiers. We have Rush University Medical Center at the top, followed by University of Chicago, and then Advocate Christ Medical Center here, just as 3 examples. What I'll do is I'll zoom in on the Rush example. What we're showing is 4 different metrics, essentially. We have the program name to the left. We have a distance. If the person executing the search wants to enter their zip code, we can provide a distance from their zip code to the center. If they don't choose to provide that, that will just show as a not available there. We show how many transplants they performed last year. That's the volume. We have a numerical transplant rate, so this is our measure of how quickly are patients being transplanted at their program. And then we have this 5-tier outcome assessment. Then the user has a choice. To the left, they can view summary data in the link, which brings up more detailed information, but still in a summary format for the program, or the complete SRTR report for the program in a PDF format. So again, these search results are simply meant to display sort of the high-level metrics for programs to quickly find and compare these programs. So this is, again, you've seen this slide already. This is what the 3 tiers looked like for those adult kidney programs. And I'll just flip to the next. If you focus on the green dots in the middle, what happens when we institute this 5-tier system is the green dots now become colored like this, so we get better differentiation of programs into these 5 groups. So the blue ones at the bottom are now the best. You'll notice that the system does put more programs into that better group in the bottom, the blue group, than the previous system did. And then we get these sort of bands of color as you go up across the different tiers. And in terms of how many programs land within each tier, certainly most programs are in the Tier 3 and Tier 4 groups. So you'll see the biggest numbers there. These numbers in this table are numbers of transplant programs by organ. So if you look at heart in the top row, we had 8 programs in Tier 1, which is the worst than expected, 8 programs in Tier 5 at the right, and then the others stratify out across the 3 tiers in the middle. So we think this is a better spread of program performance, more useful for patients when considering the level of outcomes at the different programs. Now, you saw the box plot on the left under the 3-tier system, and recall that I was focusing you in on the width of that box, how tall it is, in other words, in the as expected tier. And you can see that the spread across the different tiers is much more uniform across the 5-tier, so that programs that are within each tier, you can be more certain that they're performing approximately within this narrower band of performance relative to their peers. So what are the actual differences across the programs for first-year graft failure rates across the tiers? You'll see lots of percentages on this plot. I will walk you through the heart column. So if a program is in the better than expected, this is saying that the first-year failure rate for those heart transplants is at 5.5% within the best grouping of programs. Compare that to the bottom row. In the programs in the worse than expected, the failure rate in the first year was 18.5% on average across those programs in that first year. And you can see the spread across those programs. I think it's helpful to not digest a whole table full of percentages. So what I'll do is I put these on a figure on the next slide, and so you can see the relationship. So for the lung programs at the top, those in Tier 5, which is the left, 7.5% failure rate in the first year versus 24.4% in Tier 1 across to the right. And you can see a little bit narrower spread for liver, quite a bit narrower for kidney, 2.6 up to 8.8%, and 5.5 again with heart up to 18.5. So you can see the actual spread in outcomes across those tiers. One of the criticisms that come forward is that that spread within the kidney grouping is so narrow that we shouldn't really be trying to dice up performance across those spread from 2% up to 8.8%. When you look at the relative failure rates within these groupings, which is on the next slide, these are saying what's the relative performance. And now the best way to look at this table is if you focus on the tier 3, which is the good as expected, right in the middle of this table. These are all about 1, right? So they're about, you're performing about what national expectation would be if you're in tier 3, the good grouping. And it's just saying that for all of these programs, those up in the better than expected are about half the event rate is what you expect. That's why they're about 0.5. And those in the worse than expected are up around 1.8, 1.9, almost 2, double the event rate in tier 1. And when you look at those numbers next to each other, now these are relative failure rates, you'll see again, although kidney was a narrower grouping overall, and that's because the success rates are higher in kidney transplant, relative to each other, the failure rates stratify out about the same across the different organ types. So we're talking about failure rates about half what we would expect up to about double what we would expect across the tiers. Can we know what the probability is that a program in a higher tier is better than a program in a lower tier? We can actually put some numbers around that. There's always uncertainty. Anytime we measure things, there's always some random variation that can occur and some uncertainty. And so the SRTR has run some simulation studies where we simulate program performance and we look at this tiering system and say, we answer the question, what's the probability that if I'm a tier 5 program, I'm better than a tier 4 program in reality, or is that just random noise? And so you can see if you look at the tier 5 column, which is the leftmost column on this table, this is saying that if I'm a tier 5 program, the probability that I'm better than a tier 4 program is 0.72. So about 3/4 probability that that's true. So a probability of 1 means we're 100% certain. A probability of 0 means we're not certain at all. And you can see that probability goes up the more tiers you get away. So a tier 5 program, we're 98% certain that they're better than that tier 1 program. So you can see how these percentages stratify out. Certainly, as the tiers get closer, those probabilities are closer to 0.5, which would be a coin toss that we don't really know. One of the questions that comes to us frequently is, are these differences in the tiers actually statistically significant? In other words, is this just random noise, or are these actual statistically different outcomes in performance across these tiers? And that's what this table is, a bunch of numbers. Won't focus in on them here, but the p-values for all of the comparisons across the tiers are in the parentheses. For any statisticians or other interested in on the webinar, you'll notice that the p-values are all quite small when we compare patient outcomes in one tier versus another tier. The tiers are a highly significant predictor of outcomes at the different programs within those tiers. So after the launch, HRSA received feedback from the community that was concerning to them and felt that it was prudent to roll back the system to the 3-tier. And so the SRTR executed that request as quickly as possible to put the 3-tier back up on the public website. HRSA asked that the SRTR move the 5-tier system to a beta site for further discussion, and we're hoping that today's webinar will spawn some further comment. So that exists on beta.srtr.org. That happened on February 21st. And again, we are seeking comments. So please, any of you on the webinar, please feel free to send your comments to us, srtr@srtr.org. We compile those weekly, provide those up to HRSA for future consideration. So where are we going to go from here? I just want to talk about some of the feedback that we've gotten today. We're hoping to get more. This is feedback that was positive regarding the tiers. Some comments from folks that wrote into us. I picked a few here. When assessing a program from a patient perspective using a 3-tier system, it is really not useful for a patient to choose a program in the area, given about 95% of all programs are shown as performing as expected using the 3-tier system. Just picking off some of the comments here. 5-tier system is given a hope. Much user-friendly, easier, practical for patients to choose a program for transplant. I urge HRSA and the SRTR to revert to the 5-tier system in accordance with the final rule. Bottom bottom comment, 5-tier system is clearly a much better differentiator than the 3-tier system, and the charts providing statistical likelihood that one program is better than another in terms of outcomes was a great addition on the new website. I like the second comment on this slide. It's devilishly hard to satisfy all stakeholders when making comparisons. I hope patient needs are top of mind in vetting the 5-tier system. I am a patient trying to get a kidney transplant. I have seen reporting by the SRTR using 3-tier and 5-tier systems in the last month. 3-tier system is useless for patients like me. Please change back to the 5-tier. Finally, I'm the parent of a future kidney recipient. The 5-tier is a lot better than the 3-tier, even if it's not tailored to finding information on pediatric programs, which, as a side note, is something the SRTR is also working to improve how we are displaying these information for pediatric programs. Some of the themes from the concerns we've received focus on these types of critiques, that this system focuses too much attention on the first-year outcomes when getting a transplant at all is more important to patient outcomes. This is something that the SRTR, we're actively working on. I'll show you an example of that, is how can we recall that we present 4 metrics, right? How close is the program to your home? How many transplants did they perform? What was their transplant rate? In other words, how quickly can we get transplanted at that program? And then finally, the outcomes. So we're actively looking at ways to make that transplant rate better so that not all of the attention is focused on that outcome, that there are other important metrics. So we agree with this. This is something we're actually working on to improve. Second bullet here, patients often do not have a choice of where to list for a transplant due to geographic or payer constraints. Therefore, ratings simply cause anxiety for patients and providers. The differences are not clinically meaningful or statistically significant across the tiers. There's too much inaccuracy in the assessments due to lack of data on risk factors. And ratings will cause programs to decline patients or donors with high-risk profiles, therefore limiting access for patients. These are, I'd say, the biggest themes of the criticisms that we've received. And these are things that we're actively looking at, working towards trying to improve, make the system better. So what are the things that we're doing? I mentioned previously the AHRQ-funded initiative to look at developing better report cards for patients to consume the information. So Dr. Israni and Dr. Schaffhausen's project, these are the long-term aims. They're determining which transplant center characteristics are presented to transplant candidates and how to present those characteristics clearly in the report card. They're trying to develop a patient-centered website and printouts of SRTR report cards to effectively communicate comparative information across transplant centers and evaluate the effectiveness of patient-centered SRTR report cards among the candidates. This is a project that's ongoing, and we are getting lots of great feedback from this already. One of the things they're actually studying is, well, this notion of focusing too much attention on the outcome assessment. And you can see on the left, this is essentially the type of information on our website now. And we have the distance, the transplant rate, and the outcome assessment. And they've actually already run a trial where they changed the transplant rate to a 5-tier rating that looks similar to the outcome assessment as a way to sort of draw the eye to both of those outcomes as being important rather than focusing too much attention on the outcome assessment. And you can see at the results of their study at the bottom, when they did this, there were more people that were choosing that program with the higher transplant rate in the middle, which we dubbed the Lake Hospital, than there were under the old system. So this is something we will be discussing with our visiting committee. Are there ways we can add metrics to this and present them in a way that does not overemphasize the outcomes? If getting transplanted at all is better for the patient's survival, we certainly want to draw attention to that. What is the path forward? Public comments will be reviewed by the SRTR Visiting Committee on May 9th. That's our upcoming meeting. The Visiting Committee hopes to make a recommendation to HRSA following that meeting. We are continuing with the AHRQ-funded initiative to continue to study ways that patients react and how they use the information presented on the website. So we'll continue to gain insights from that study. And we will then work with HRSA to determine the next steps. Next steps will be communicated to the transplant community prior to implementation. And we hope that some of our Twitter postings and other modes of communication, we have newsletter now that if you want to follow us there, those are great ways to stay in touch with the initiatives that we're working on. So with that, I thank you for listening. I will get through a lot of material, and if you have questions, I'm here with Mona Shatter on our team. She's our marketing and communications specialist, and she has been watching the questions come in, and she is going to moderate our Q&A session. So I will invite Mona into the discussion, and we'll try it as best we can to answer as many questions as we can. If we don't get to your question today, we'll work on a solution to posting responses to the question when we post the recording of this video, which we will announce on our website when the webinar is available to view. So, Mona, any questions I can address?
All right, thanks, Dr. Schneider. The first question that came in is, are the differences between tiers 4 and 5 statistically significant? Tiers 3 and 4, tiers 2 and 3, and so on.
Yeah, great question. Again, that's something that we looked at, and I showed a slide on the statistical significance question. I'll just back up to that table. It wasn't too far back. Here we go. So this analysis here was evaluating patient outcomes within the tiers to see if the tiers were significant predictors of outcomes at those programs. And you can see the results here. The levels of significance are there, which can be subjective. If statisticians in the room wanted to do a multiple adjustments comparison on that table, or multiple comparisons adjustment, excuse me, those are still significant at a level that would clear that multiple adjustment comparison as well. So certainly anytime we're measuring outcomes, we have uncertainty, but we think that the tiers are a good differentiator, better than the 3-tier system about performance, certainly within that middle tier.
Okay, the next question is, what if you change the name of tier to star, like dialysis facility compare does?
Also a great question. It's interesting during the full development process of the system, I wish I had written down the number of different symbols and ways to convey a tiering system, right? We're essentially categorizing programs into groups. Stars were, of course, considered along with, I would say, 10 other types of symbols that are in common use, consumer report style symbols and such. When stars were put forward, we actually piloted stars to the Transplant Administrators Committee and the Transplant Coordinators Committee during our presentations. And the feedback was overwhelming that stars were sort of ubiquitous in society, and sort of the committees didn't feel that stars really represented the complexity of the transplant process and programs, and urged us not to use stars. HRSA heard those recommendations and asked us to use a different type of symbol, which led to the tiers. So we don't like to call this a star rating. It's a categorical rating for sure, but we didn't want to use stars sort of to make it just differentiate it a bit from other common systems. And it's also based on data. It's not based on sort of user feedback, if you will, like an Amazon star system where it's users are saying, I liked this or I did not like this, and therefore I have a star rating. So I wanted to make it clear this is not what that is.
The next question is, will patient and center usability testing be completed prior to re-release of the 5-tier system per AHRQ recommendations?
Good question. I would say the path forward, once we hear recommendations from the community and go back to HRSA and our visiting committee with this, the goal there is to vet these recommendations and how we should proceed. So I think that certainly we heard loud and clear the feedback from the transplant community that they felt unaware of the change and weren't able to see it before it was live. So certainly that's something we want to correct in the future. Using our secure website or some other type of way to communicate those changes with the programs ahead of time and gather feedback, I think is prudent, and that would be the path we would go down. But certainly we need to vet those recommendations with the visiting committee and with HRSA as well.
Okay. The next question is, program size has an impact on the variability of the program score. How have you made this more understandable to patients?
Also a great question. One of the challenges that we have in this system, or any system for that matter, is the different sizes of transplant programs. We have more information when we have large numbers of transplants being done at programs than we do for smaller programs. And so the tiering system that we have today takes two things into account. It takes what the actual observed performance was at the program, as well as the variability, in other words, the uncertainty associated with that assessment. If you recall the bell-shaped curve that I showed on one slide that showed this is how we're converting that bell to a tier, the bigger programs have a narrower bell curve, and the smaller programs have wider. That means that we have less certainty with smaller programs than bigger programs. And so the scoring system that is used to result in one of the 5 tiers takes into account both what the actual assessment was as well as how certain are we of that assessment. The new system actually performs better in differentiating that sort of big program versus small program issue than the 3-tier system did previously. In the old system, the ranking of the program or the tiering of the program was completely dependent on the size, the bigger program in the comparison, whereas now it depends on both the smaller program and the larger program. So certainly it's a challenge anytime that we are evaluating programs of different size, these issues of certainty come into play. But we believe that the 5-tier system actually handles that problem better than the 3-tier system did.
The next question is, why only rate graft survival? SRTR used to do graft and patient survival.
Also something that we debated during the initial development of the site. It was thought that putting more metrics was less optimal than fewer metrics. Some of the recommendations we were hearing were to sort of simplify and don't try to present too much. So we did have a prototype where we had both the patient and graft survival. Then we went with just patient survival. Then we had gone to graft survival. And so lots of different ideas and concepts were vetted. We landed on graft survival simply to pick one outcome to present first, and because our ability to differentiate is a bit higher when we're looking at graft survival because event rates are higher than patient survival event rates. So we have a bit more certainty, all else equal, when we're looking at graft outcomes rather than patient outcomes at programs. And so it was decided by the visiting committee, let's go with graft survival initially. And certainly if you click on the view summary data for the program in the search results, you are presented with all of those outcomes, patient and graft survival, as well as living donor survival, deceased donor survival. So there's lots of metrics, but I think the recommendation was just pick one to start. Certainly if you have recommendations for ways to make that better, we'd like to hear about that. But that was the rationale for choosing graft survival.
Next question, would SRTR consider not counting death with a functioning graft as a graft failure?
Also a good question. When we look at survival in transplant patients, there's a couple different ways we can think of that question, right? One is overall survival, regardless of what happens to the transplant, which we would typically we've called patient survival, right? So that's saying from the day you were transplanted, how likely are you to be alive at 1 year or 3 years, regardless of if your transplant is functioning or not. If you're a kidney recipient, for example, you may go back on dialysis, but still be alive. Then there's the typical graft failure, which is a combined endpoint, which is you lost your transplant or you died. That's the way it's done on our site now. So we're really looking at the success of the transplant. And so we're counting both the graft function and the ability to keep the patient alive as the outcome of interest. Death-censored graft failure is something that we look at for other reports. We look at that in the annual data report that we produce jointly with the OPTN and SRTR as a way of looking at graft failure that didn't result in death. The idea being that patients can die for reasons unrelated to graft issues, although that's hard for us to tease out. So for these types of reports, we've always looked at both graft failure and patient survival overall. But we have never made a move toward death-censored graft failure.
Our final question is, transplant rates are as important as 1-year outcomes. Can you combine the two into a single numeric ranking?
Also a great question. These are really fantastic questions. This is something that we've debated also over the years. And it really gets to the idea of a composite metric. In other words, there are lots of things that are important about a program, and can we come up with some overall score that combines the concepts together? Our stance on that has been that we've looked at different ways to do this, to construct these types of composites, and this is something that the AHRQ-funded initiative is also looking at. Are composite metrics actually better for conveying the ideas to patients than a single metric? But for now, what we haven't liked about the composites is if you're really good at one, in other words, let's just say transplant rate and outcomes, if you really have a stellar transplant rate but your outcomes are very poor, when you combine those together, however you're going to decide to weight those two metrics together, you may look average, even though you're really good at one and you're not so good at the other. So is that the best way to compare programs? I think there could be a reasonable debate about is that a good thing to do or not a good thing to do. The second part that we don't like about it is how do we decide how much weight to give one or the other? I think that's maybe patients can maybe supply their own weights. We've actually talked about ways to say, well, what's most important to you, getting transplanted fast or having a really great outcome at your program? Maybe they could upweight those transplant rates. But for now, we've sort of moved in the direction of, rather than trying to come up with a scoring system that combines these together into a composite score, just simply say, if these are important metrics for patients to consider, let's present them side by side in a way that can convey a message to a patient that maybe they should emphasize the transplant rate over the outcomes, that getting transplanted at all is a better situation for their life rather than getting transplanted at the program that has the absolute best outcomes. So we're studying that. Transplant composite scores aren't off the table, but generally it hasn't been, I'd say it's not like the primary focus of where we're headed with it. So again, it's top of the hour, and if we did not get to your question, we will do our best to address all questions when we post the video. I thank you all for attending, and I urge you to submit your feedback, both positive and negative, at srtr@srtr.org, and we will compile that and get that information up to our visiting committee and HRSA. So thank you all for attending, and we hope to see you soon. Thanks.